So let's just keep on going with these polyps, and I'm going to get some of you guys to do some of this. We still have to remember we're looking for the polypectomy site. Let's characterize this lesion. So what do we think about it, Florence?
First blink is okay.
Blink
I
is
don't
okay.
see
Good.
malignancy.
Yeah.
I don't see a demarcation zone. It's a small lesion. I think it's under 10 millimeters, maybe 8 millimeters or something.
Cap is 13 or 14, maybe 15. So it's a 8, 9, 10 maybe. Yeah.
Looks like a tubular adenomata. When we see to pit pattern, it's a GNET2A. So it looks more like tubular adenomata. I don't see signs of deep mucosal invasion. So I would go for a cold snare resection.
And why are you going cold snare?
Because it's less than 10 millimeters.
And you can stop. I think that's perfect. Thank you, Florence. Very good. So there's plenty of polyps here. So let's do one, and then we'll talk about the technique together, me, you, and Sarah, and then you guys take over for doing the other polyps. So tell me some things that I want to think about when doing cold snare polypectomy.
First, about your axis. Yeah, you want to have a stable position. I think you have it. You want to have the polyp at 6 o'clock.
And maybe we should ask, Lynn, someone said, who was it that said that they wanted to focus on cold snare? It was you, wasn't it? Was it you?
As well.
Yeah, okay. So what do you find the most difficult about cold snare? Is it the access?
Open.
Yeah,
access, and I know that you can't take enough normal tissue in it, but sometimes I'm doubling if I'm still not taking too much, and then you have like the pulling technique, then you have the stock.
Yeah, well that's important, and I think that's when you're on a fold more than taking too much normal. Let's focus on this for a minute, and then we come back to that because we may see that later. So what do we think about this position?
Yeah, it's perfect position. Enough normal. You have the complete polyp in it. You have the V. Maybe we don't see the tip, so maybe, but yeah, you know where you place it.
So I actually do prefer this with cold snare, so I don't completely see the V, so I can really exert pressure. So one of the real differences between hot snare and cold snare technique is that you want to pin the polyp down with cold snare, right? So in hot snare, this would be a not acceptable position, because as soon as this closes with a hot snare, probably it's going to slip over and cut the, de-roof the polyp, if you like. Here in cold snare, if I push out, then I can really pin the polyp down to get the most tissue possible. And you're absolutely right. It's the rim of normal that you can see all the way around. So maybe it's not at 6. Maybe I can make it more at 6 so you can see the back and just prove to you that at the back there's a normal rim. But absolutely. And then really you can push the snare catheter out. So if you look at my right hand, often in cold snare polypectomy, it's on the snare catheter. Then it's a case of closure. Now, I think cold snare polypectomy, you can close as fast as you want. So let's just try that. Just close, Yuli. Stop. So as you watched it close, there's a little blink that the edges are coming in or not, right? Yeah. You saw it there, and we can review it on the video later. The edges are coming in, and the polyp's in the middle. All right. So what would you then do? Ask the nurse to do now that it's like this.
Yeah, she may cut.
She may cut it. Yeah. So just cut it off, Yuli. Wait. Okay. She's cut it. It has cut, but this. Look at this. You can already see that this is an en bloc resection just from the edges coming in, and now we have the polyp off, and maybe we can even see here that we have a fried egg. We have a yolk in the middle, and we have the edge completely in. So I didn't show this yesterday. It's not a bad image actually that we could use for one of our publications.
David,
pardon me?
Can I come in?
Yeah.
Can I just make a couple of points? The first one is that the cold snare wire is a little bit thinner, and the reason you can push it out is it effectively pins the mucosa, but the snare gives a little bit and basically it lines itself along the muscle there, whereas with a hot snare it's a little bit stiffer, and if you come into the muscle there slightly tangentially, you run the risk of damaging. The second thing is, and it's a critical thing you did, before you cut through completely, you relaxed the tension on your deflection, and the way you did that is you withdrew the catheter back into the scope, and it changed the angle at which you were cutting through and facilitated the cold snare cutting through the submucosal plane. So it's something you did on autopilot once you'd got the snare snug, because you obviously don't want any tissue to lose, but you change the angle at which the snare was out from being slightly, well, not parallel to the muscle layer to becoming parallel to this muscle layer for the transection of the lesion.
So is it wrong to use cold snare for this?
I always find it difficult. I thought it depends on the stock. How yeah, it's not that big. I think it's less than 1 centimeter.
Definitely.
So I think this could be with cold.
I agree. I think pedunculated or not, under 10 millimeters, you can always do cold. John, would you agree with that? We don't hear you, John.
Sorry, I was on mute. Yeah, there's very few reasons not to do it cold. As I say, as you get increasing size of the polyp, it may become more difficult, but you can overcome that by using a lift. Most of the guidelines, in fact, all of the guidelines that I'm aware of, advocate cold snaring for lesions of less than 10 millimeters.
They often don't specify. I think we need to be clear. They often don't specify pedunculated or not, do they? But indeed, anything. I think we should give the message anything. And that probably lifting, John, here might have made it a little bit easier, to be honest.
Yeah, but you did get it off, and that little tuft is really just some connective tissue drawn together, and you don't need to worry about that.
Just one other thing, Florence asked whether she might reposition the snare, and you said no. And Lob had made the observation in a previous time that I think it was a course that if you reposition the snare, it just often ends up in the groove that you've already created in this situation.
Yeah, and I mean, I think that, yeah, it was borderline, wasn't it? Injection may have helped, but I mean, really, we want to emphasize in cold snare pinning the polyp down, and that's what you did there. You really pinned it against the wall and cut it off, and look how well it's worked.
Yeah.
And you've beautifully demonstrated that you've got no residual.
You got to work up the pros and cons. So the pros of doing nothing, or it's dead easy, but you run the risk of having significant bleeding afterwards. That may be more difficult to control. The injection is really easy to do. The clip and the loop will possibly make the snare placement more challenging and will give you less stalk to play with in terms of where your snare position is. And you want to make sure you get all the adenomatous tissue at the top. You know, you don't want to have an incomplete resection. The second issue, which is probably not so well known, is there is a phenomenon called coaptation. So when you're using a monopolar snare, it needs to earth through the plate, and the current density will be highest where you get compression of the diameter of the stalk. And if you've got a loop below where you're putting the diathermy, yes, you'll get diathermy effect at the level of the stalk, but you're also going to get it at the level of the loop. And that depends on how tight the loop is. If you're applying a loop, it needs to be tight enough to occlude the blood vessel, but not too tight so you cheese wire the stalk. If you're applying a clip, the clip has to be across the whole stalk and has to be tight enough to sufficiently cut off the blood supply through the vessel. So there are lots of things to think about pros and cons. From a personal perspective, whatever you're doing, you need to be really familiar with that particular technique, is what I would suggest. And you need to be able to deal with the complications if they don't work. So here, there's a window of opportunity where you want to pull the snare. We call it a pull-push technique, where you pull the snare back, you push it forward. And what you're doing is embedding the snare around the base where the lesion attaches itself to the mucosa to make sure you've got complete resection of the lesion. We pull back and forward until we've got the polyp in view and you've got the V in view. And what we're doing is we're using the snare to push the mucosa away so we can view the V at the bottom and then ensure that the snare is in the right plane. And it doesn't sound very complicated, but there are lots of individual components there, David, that you don't just have to do, but you have to do in a timely and coordinated fashion. And the timing is critical.